virtual series. I am LaSonia Barnett, the Senior Program Coordinator for the office. This evening, we will have 2 DCI providers that will speak on leukemia, lymphoma, multiple myeloma, and myelodysplastic syndrome, as well as a cancer survivor that will tell her story that will bring these 2 providers together. This presentation will shed light on the great work that our DCI providers provide to our community. We hope that this presentation is most informative for you. Please feel free to put your questions in the chat, as these questions will be presented to the speakers during the question and answer Q&A session at the end. So let's begin. Here is our agenda for this evening. Let everybody take a brief look at it, and we will begin. First up, we have Dr. Nelson Chow. Dr. Nelson Chow is a professor of medicine, a Donald D. and Elizabeth G. Cook Cancer Distinguished Research Professor, a professor in immunology, and a research professor of global health. He is a professor in pathology and the Chief Division of Cell Therapy in the Department of Medicine and a member of the Duke Cancer Institute. He graduated cum laude from Harvard University with honors from Yale University and with his MBA from Duke University. His research interests are in 2 broad areas: clinical stem cell and cord blood transplantation, and the laboratory studies related to graft versus host disease and immune reconstitution. Dr. Chow has been employed at Duke for 26 years. Prior to that, he worked at Stanford for 14 years. Let's welcome Dr. Nelson Chow.
Thank you very much. So I have a quick task today. So we're going to start with leukemia. Leukemia is a cancer of white blood cells. We call these acute or chronic leukemias, depending on the pace of their disease. It affects the ability to produce bone marrow. And the bone marrow makes an abnormally large number of immature white blood cells called blasts. Next slide, please. If you look at the demographics of patients, the majority of these leukemia tend to be acute myeloleukemia, or AML, that yellow. There's chronic lymphocytic leukemia at 26%, acute lymphoblastic leukemia at 11%, chronic myelogenous leukemia at 15%, and 17% of others. Next slide, please. The risk factors, we do not know exactly what causes leukemia. There are some exposures, such as high energy radiation. There's some genetic syndromes. And there are folks which in the past used to work with benzene for a long period of time. Next slide, please. The signs of leukemia vary quite a bit, but many times patients show up with symptoms of the flu. And obviously this varies depending on the kind of leukemia, but being tired, frequent infections, easy bruising or bleeding, bone pain, headaches, enlarged lymph nodes, low red blood count, pale skin, poor appetite, all could be signs of leukemia. Next slide, please. Tests for diagnosis, one could look at a finger prick if you are able to do a slide. Obviously the blood sample, a complete blood count would be the best. There's a blood dye that we do, which dyes the white blood cells so we can actually look under the microscope. A bone marrow sample is the way to diagnose it. And for certain diseases that can actually go to the spinal fluid, a spinal tap or lumbar puncture is necessary. Next slide, please. So here's a picture of the blood. On the left-hand side of the screen is normal human blood. And you can see red cells, platelets, which are those little fragments, and a white blood cell in the center there. And if you look at a patient with leukemia, you see that there are some red cells in there. There are a few platelets. There are a few normal cells, but you can see those big cells in the purple, and those are the blasts. Next slide, please. So it varies a lot what the clinical course is. Median survival is somewhere between 3.5 to 8 years. Obviously, acute is shorter, chronic may be longer. Patients can go from chronic to accelerated phase and then an acute phase. And in an acute phase or in blast crisis, you have lots of blasts, and these patients tend to do poorer because the disease has accelerated. Next slide, please. So there have been many advances made in the last couple of years. So we've had chemotherapy, immunotherapy, radiotherapy, and then bone marrow transplant. And many new therapies are coming along for these diseases. Next slide, please. So that's sort of a quick snapshot of leukemias. I'm going to switch over now to multiple myeloma. Multiple myeloma is a cancer of the bone marrow as well. So remember, the leukemia was a cancer of the blasts in the bone marrow. This is a cancer of plasma cells. Plasma cells are cells that we have in our bodies. Normal, these can be normal, that makes antibodies. So these are abnormal plasma cells. They disrupt normal bone marrow function. They reduce normal immune function. It results in an abnormal production and release of these monoclonal proteins or these antibodies into the blood and the urine, and it destroys and invades the surrounding bone. Next slide, please. In terms of cases, there are about 24,000 every year, 11,000 deaths. Median age of diagnosis is 62. 5-year relative survival is about 45%. Number of deaths have decreased. The risk factors is unknown in most of the cases, but it increases with age, male sex, obesity, and in the Black race. There's variable response to treatment. It varies from a few months to more than 10 years. High risk attributes are thought to play the primary role, and not enough patients survive, unfortunately. But now with novel agents, some of these outcomes might actually be better. Next slide, please. So myeloma also results in a broad spectrum of clinical manifestation. So because these myeloma cells are making this M protein or this monoclonal antibody, these antibodies can actually clog up the kidneys. It can cause neuropathy, or it can make your blood too thick. And it can cause a disease called amyloidosis, which is deposition of these proteins in certain organs. These cells can cause immunodeficiency because they're abnormally crowding out normal cells. And then because they're infiltrating the bone marrow, or they're growing in the bone marrow, it destroys the bone. It leads to high calcium, bone pain, lytic lesion, meaning it leads to holes in the bone and to anemia or low red cells. Next slide, please. So the disease usually is from what we call a monoclonal gammopathy to a smoldering myeloma to multiple myeloma. And we don't think of this monoclonal gammopathy as a cancer, but with time, it can lead to become a cancer. And as it develops, it becomes more aggressive and it becomes less dependent on the surrounding tissue. And the common features of myeloma are this thing called CRAB, which is C for calcium, R for renal dysfunction, A for anemia, and the B for bone disease. Next slide, please. So in terms of figuring out who has myeloma or not, there's, as you can see on the left-hand side, a whole battery test that we do. I'm not going to go through all this, but suffice to say that there's a lot of blood tests that we do. We do radiology with us to look at the bones for these bone lesions. And sometimes the PET scan is quite useful. And this helps us to determine the type of myeloma and helps us do the staging. And with some of these tests, especially with the cytogenetics, it helps us to estimate prognosis and the need to intervene urgently or not, especially with patients, for example, with high calcium or cord compression. Next slide, please. There's a staging system, so it goes from stage 1 to stage 3, and it's dependent on this protein called beta-2 microglobulin, as well as a serum albumin. And not surprisingly, the higher the stage, the less the median overall survival. Next slide, please. We do know that the cytogenetics, or the chromosome findings in these cells makes a difference. So if you have certain chromosomal abnormalities that place you in the high risk, the overall survival is poor. It's only 3 years. Whereas the standard risk, which is those that are not either high risk or low risk, have an overall survival about 8 to 10 years. Next slide, please. The natural history is shown in this cartoon. Patients really don't have symptoms, and normally what happens is you get a first-line therapy, your protein goes down, you get a second line, it starts to go up, you get a second line therapy, the protein does not go down as far, you get the third line, you get less and less response. And that's basically what that line is showing you, is you get the best response up front, but we're not curing enough patients, and so the disease comes back, and when it comes back, it doesn't respond as well. And then at a certain point after multiple lines of therapy, it no longer responds to anything. Next slide, please. So the treatment of this is you confirm the diagnosis. If they're transplant eligible, you treat them and take them to bone marrow transplant. If they're not eligible, you treat them with a variety of different chemotherapy or targeted therapies to try to get them to complete remission. And you basically stay on this therapy until you have progression. Next slide, please. So the clinical considerations for patients is the tumor burden, so how much myeloma they have, whether their kidneys are working, whether they have high calcium, whether they're frail, so you try to avoid dexamethasone as a steroid, whether they have clotting or bleeding, so you have to be careful depending on the type of drug you're going to use, whether they have neuropathy, so if they have neuropathy, you may not want to use certain drugs for myeloma, and cytogenetic abnormalities, you might want to use certain drugs if they have high risk. Next slide.
You have 2 minutes.
Next slide. Oh, that was it.
Thank you very much, Dr. Chow.
All righty.
Next, we have Mildred Bethea. Mildred is the founder of Driving for Change, a grassroots movement to advocate and educate in hopes of enhancing the Beta-Match bone marrow registry with more diverse ethnic donors. Also making mothers aware of public and biblical cord donating possibilities. Mildred is a certified patient navigator from the Dr. Harold P. Freeman Patient Navigation Institute out of Harlem, New York. She's a Duke Cancer Institute Office of Health Equity Community Health Ambassador as well. Mildred is a 3-time cancer survivor and recipient of a stem cell transplant, which saved her life. We'll introduce to you Mildred Bethea.
Good evening, everyone. After listening to Dr. Chow, I'm sitting over here trying to keep my eyes dry because so much of what he explained has been my journey. First of all, I'd like to say how grateful I am to even be alive, as well as to be a part of this presentation tonight. My journey begins, actually, I was thinking about it 19 years ago. July of 2002, I was first diagnosed with breast cancer. That was the beginning of just my entire journey. With the breast cancer, I went through a mastectomy. I went through 6 months of chemotherapy and reconstruction. And sometime after that, it seemed that my white blood cells were just not coming back. They were lagging. And my local oncologist here, Dr. Birgit Arb, she started the process of doing bone marrow biopsies to kind of try to figure out what was going on with my white blood cells. And we did that for a period of 2 years, and they kept coming back, not really telling her anything. And towards the end of 2005, as opposed to them just being in a lagging place, they decreased a little bit more. And that was when she decided to reach out to Duke, and at that time sent me to see Dr. DeCastro. I will never forget the day I walked in his office. I can remember the date, December 28th of 2015. And it was in his office, he did his own bone marrow extraction. And he looked at my cells under the microscope, and he told me then that he could see the leukemia prior to it even going to pathology, and that I needed to get back to Duke as soon as possible. With that being the end of the year, it was shortly right after the new year, I went back to Duke and I became an inpatient where I was diagnosed with AML. And I stayed in the hospital from the beginning of January until the middle of March. And during that time, I went through chemotherapy, but also because of how intense the chemotherapy was, I also experienced a whole bunch of other unexpected situations like congestive heart failure and aspergillosis of the lungs and MRSA and VRE and partial bowel obstruction. It was like, I just did not even think I was going to walk out of the hospital. And by the grace of God, I left Duke that March of 2016 in remission, surprisingly. I was in remission probably, I don't know, probably until sometimes in 2017 when I was now diagnosed with myelodysplastic syndrome. And it was explained to me that myelodysplastic syndrome was a precursor to the leukemia trying to return. So fortunate for me, I was able to be on 8 months of chemotherapy at that time without having to be an inpatient again. So I continued to work. I was in school, and I also was becoming a caretaker of an elderly parent. Towards the end of 2017, it was decided that once I got in remission, if I got in remission, then I needed to consider having a bone marrow transplant. Needless to say, I was also told in the next breath that if I didn't have a family match, the likelihood of me finding a match in the bone marrow registry was none, no to none. And that was because I was African American. So imagine having all these things going on, and now because I'm Black, that being an issue for me getting a transplant. I really didn't understand any of that. But as I started to educate myself, it became really apparent to me why the odds were like they were. So no, I did not have a family match. And when we searched the registry at that time in 2007, it was over 7 million people in the registry, and I actually matched not one. But fortunately for me, again, Duke holds a public cord blood bank under the umbrella of Carolina Cord Blood. And I actually matched one baby's cord blood in that bank. And I remember being told that it was less than a 10% chance that I may survive the transplant because of all the processes they would have to take me through in order for me to get the baby stem cells. But fortunately for me, we went through the processes, and I'm able to sit here today saying that my health has been restored. I've been cancer-free for almost 14 years. It will be this coming November the 5th, if God see fit for me to remain. My blood type has changed, and I have just been living in my blessing, which I call my extended life. As a result of that, Driving for Change came forth in 2009. And the reason why Driving for Change came forth was because I couldn't help but to remember what my experience is or was, and that there were other patients out there that looked like me or that were considered minority ethnicity that would run across the same issues. So I had hoped that through my journey, my experience, my strength and hope, that I could add more minority people to the registry and also educate mothers about the public umbilical cord bank. Since that time, that's what I have continued to do. The logo you see in the background is my Driving for Change logo. It didn't exactly start off like that. It was just initially the 5 stick people, which represented minority ethnicity. And then over the course of time, it dawned on me that I was actually living off the umbilical cord stem cells and that my logo didn't represent that. So I expounded on the stick people, added a faceless baby, attached the umbilical cord in hopes that the logo itself would tell a story. And I think that it does. but I do continue to advocate. I'm no longer with Carolina Cord Blood Bank through Duke as of a couple of years ago because they don't provide the kit any longer. But I am now affiliated with a bank in Florida, and I still advocate. And through that bank, we are able to do cord blood donation throughout the continental United States. And that is my story of survival in my life.
Thank you, Mildred.
Thank you.
What a wonderful story. We're so glad that there was that umbilical cord of that baby boy to save your life, because then if it wasn't for you, we wouldn't hear your story. So thank you so much. We appreciate it.
Thank you for having me.
You're welcome. So next up, we have Dr. Carlos de Castro. Dr. Carlos de Castro is currently a professor of medicine at Duke University in the Division of Hematologic Malignancy and Cellular Therapy, Department of Medicine, and he's a member of the Duke Cancer Institute. He received his undergrad degree from Duke in biomedical engineering. He then attended medical school at the University of Texas Southwest in Dallas, where he completed a residency in internal medicine. He to Duke for a fellowship in hematological oncology at that point. His clinical research focuses on treatments for bone marrow failure conditions, such as paroxysmal nocturnal hemoglobinuria at PNH. Dr. de Castro has served in several roles at Duke, including medical director of the 900 Malignant Hematology Ward, medical director of the apheresis unit, medical director of the Outpatient Treatment Center, and program director of the Duke Hematology Oncology Fellowship Program. He is on the NCCN panel for myelodysplastic disorders and serves as a member of the medical board of directors for the Plastic Anemia and MDS International Foundation. We bring to you today, Dr. de Castro.
Thank you, Sonia, for having me, and thank you, Mildred, for telling your wonderful story. It always gives us hope. Next slide. So I'm going to talk today about two different topics. One is lymphomas, and the other will be myelodysplastic syndrome. And I'll start first with the lymphomas. Lymphoma is a term for many types of blood cancer. We subcategorize lymphoma into both Hodgkin lymphoma and then non-Hodgkin lymphoma, both being very different. Lymphocytes are a type of white blood cell, and they're part of our immune system. They reside in the lymph nodes, the lymphatic vessels, the blood, bone marrow, and the spleen. And lymphoma starts with a change to just one of the lymphocytes. Next slide. As you can see from this diagram, the lymph cells live all over the body, including our lymph glands, which are all over the bone marrow and the spleen and other locations. Next slide. When patients present with lymphomas, usually they come in with an enlarged and usually painless lymph node in one or more locations. And if they're peripheral, like in the neck, it's easy to see and feel them. Sometimes they're deep in the body. Other signs and symptoms include fever, drenching night sweats, significant weight loss, loss of appetite, fatigue, cough, chest pain, abdominal pain, a sense of bloating or abdominal distension when the spleen gets big, itchy skin, or rashes and skin lumps. Next slide. The diagnosis of lymphoma is based on an experienced hematopathologist looking at a biopsy specimen. Most often, this is a biopsy of a lymph node. And usually what we like to do is get a whole lymph node, but occasionally if it's difficult to get to, we'll just have to use a fine needle biopsy of a lymph node. And on that biopsy, there'll be other tests done, including what's called immunophenotyping, where we stain the cells, flow cytometry, cytogenetic analysis, and gene expression and mutation analysis, because all of this will feed into not only how to make the diagnosis, but also how to treat the patient. Next slide. We stage lymphomas by using several tests, including blood tests, imaging tests, bone marrow biopsies, heart function tests, and other tests. Next slide. And the staging system we use is what used to be referred to as the Ann Arbor staging system. If you have stage 1, it's just one group of lymph nodes in a single group. Stage 2 is 2 or more groups of lymph nodes, but on the same side of the diaphragm. Stage 3 is 2 or more groups of lymph nodes on different sides of the diaphragm. And stage 4 is widespread disease, which involves organs outside of the lymph node themselves, such as the spleen or the bone marrow. Unfortunately, most lymphomas present in either stage 3 or stage 4 by the time we find them. Next slide. There are many, many subtypes of lymphoma, and that's shown here in this slide. And like I said, it takes a very well-trained hematopathologist to go through and figure out what type of lymphoma a patient may have. And it makes a huge difference, both in terms of prognosis and survival, but also in the type of treatment that the patient will receive. Next slide. There are several risk factors for developing lymphoma. We haven't gone into this much. Age is clearly one of them. The older we get, the higher the incidence of lymphoma seems to be. Next slide. Other risk factors include things like obesity, immune suppression if patients are on that. There's been occupational exposures, such as farm workers who may be exposed to pesticides. Viruses can do it, such as EBV, HTLV1, HIV or the AIDS virus, the H. pylori, which causes ulcers in the stomach, can lead to a certain type of lymphoma called MALT. Hepatitis C has been associated with lymphomas, etc. So there's a lot of risk factors that can feed into why people develop lymphomas. But for the most part, most patients do not present with any of these, and we're left with wondering why they develop lymphomas. Next slide. Lymphoma is the 7th most frequent diagnosis in the world, and there's substantial variation in different trends for individual subtypes. We've had a lot of improvements recently in how we treat these lymphomas, including diffuse large cell B-cell lymphoma and Hodgkin's lymphoma, both of which now considered curable. There's a lot of variation between racial groups in these lymphomas, and lymphoma may be less commonly diagnosed amongst Black populations, but these same populations do not do as well as white populations for a number of lymphoma subtypes, and we're trying to understand that. And obviously, the whole field of disparities is complex with these associations, including social, environmental, biological, and patient-centric factors that feed into it. Next slide. We treat lymphomas in several different ways, and they vary. For some patients, we recommend careful observation, that is watchful waiting. If you have a very indolent lymphoma that doesn't grow very fast and you're not symptomatic, we may not treat it. We may just watch it. Other treatments include radiation therapy. Lymphoma cells are usually very sensitive to radiation. Monoclonal antibodies that have been developed, such as rituximab and others. A lot of chemotherapy drugs and regimens have been developed. And we now have immunotherapy and immunoconjugates to help us treat patients with lymphomas. And then these last two, the CAR T cells, or chimeric antigen receptor T cells, and bone marrow transplantation, I will mention on the next two slides because they're reserved for patients with relapse disease, but have made quite an impact. Next slide. So bone marrow transplantation may be recommended for patients with relapsed lymphomas. This involves giving high-dose chemotherapy and usually giving what's called an autologous stem cell transplant. That is, taking stem cells from your own body and not from somebody else. Next slide. CAR T cells are the new thing on the block, where we've actually take the patient's T cells out of their body and we engineer them using new technologies to make a new receptor on their surface. And this receptor, we hope, will bind then to the tumor cells. So we target certain antigens on these tumor cells, such as CD19. And then once we have these cells ready to go, they're grown up, expanded in vitro. And then we will give the patient chemotherapy and follow this with these CAR T cells, which will hopefully attack the tumor cells and lead to a complete remission. And this has been the latest treatment for treating a lot of lymphomas, and has been very successful in some of these lymphomas. Next slide. Ooh, that background is not very good. Moving back to a new topic, and we'll talk about myelodysplastic syndromes. Myelodysplastic syndromes are a type of cancer that come along where the bone marrow is really sick. And usually these patients will present with low blood counts. Even though the bone marrow is trying to rev up and make these cells, it just doesn't do a very good job. The average age is about 70, and about 25 to 35, where I say a third of cases progress on to acute leukemia or AML. Next slide. All right, until recently, the incidence rates in the US had not been known because we didn't consider this a cancer. We now know that it's a cancer, and it's now part of our registries. In Europe and Japan, there are about 3.5 to 12.6 cases per 100,000 people per year. And that makes it about 2 to 6 times more common than AML or acute leukemia. And for patients over the age of 70, that incidence rate rises. There's always been a concern over rising incidence rates, but that's never been proven. Next slide. And this slide, again, just shows you the curves for the incidence rates in 2017 for MDS shown in blue and for AML shown in red. And you can see after the age of 60, it starts to pick up and go straight up. Meaning it really is a disease of older people. And we think that some of this is because of an aging process. That is, as the stem cells divide, they acquire mutations, and eventually they acquire enough to become a cancer. Next slide. So these patients present usually with symptoms of bone marrow failure. That is, they drop their blood count. So if you're anemic, you feel tired, weak, short of breath when you exert yourself. If you have a low white count, you may present with infections that keep recurring. And if you have a low platelet count, you may present with easy bruising or little bleeding going on under the skin. A big spleen is fairly uncommon and is usually seen in a condition we call chronic myelomonocytic leukemia. And increasing numbers of patients are going to their doctors for their yearly follow-up, and they draw routine labs and notice that there's something wrong. There's either a low blood count of one sort, and they get referred then to a specialist such as myself. Next slide. The workup includes doing a history and physical and a lot of testing, including a blood count and looking at the blood smear, but also looking at the bone marrow, aspirin biopsy, and testing for a lot of genetic dysfunction in these samples. Next slide. And really, we look for cells that just aren't growing up right, and they look funny. So in this slide, you see some red blood cells that are abnormally shaped. You see some platelets that look funny. You see some white cells that look funny. And even the red cell, this one cell in the corner here is a cell that has a ring nucleus with the eosinophilic granules, very abnormal. Next slide. So the pathologist will look at the blood and look at the bone marrow and hopefully show us that they have dysplastic findings. We also use chromosome abnormalities because they're found in 50 to 70% of myelodysplastic syndromes, and they can help confirm that there really is something wrong. We're using flow cytometry and staining of these cells to look for abnormal expression of certain proteins, and we're now using these next generation sequencing panels to look for gene mutations in these patients. Next slide. And the number of mutations is shown here, and there's a huge number of them. There are some that are much more common on the left side of this graph, and things like TET2 and DNMT3. And some of these have prognostic factors, and some have influence on how we're going to treat the patient now. Next slide. We have to be careful with mutations because we found out that when we started finding these mutations and testing for what we'll call non-patients, that is normal people that were out there, we found these mutations in normal people who did not have any cytopenias or who may have had a very mild cytopenia. And we now call this clonal hematopoiesis and think these are precursors to eventually developing myelodysplastic syndromes. But they occur in about up to 10% of people older than the age of 65, and we need to follow these people closely. Next slide.
10 more minutes.
Prognosis varies, but it is based on things such as cytogenesis and blast counts and degrees of anemia and thrombocytopenia. And we use these scores to put together a scoring system that we call the IPSS-R. Next slide. And we can use this to sort of tell how patients are going to do. So if you have very low group, you have an average survival of 8.7 years, and that's an average. If you have very high risk factors, you have an average survival of less than a year and a higher chance of going into AML. Next slide. The treatment of MDS varies. For low risk disease or poor performance status, we may be conservative and use transfusion support and lighter therapies. For high risk disease, we may use some chemotherapy drugs. For any risk disease, we can always watch the patient for a while to sort of see how they're going to do. Next slide. Supportive care includes things such as red cell transfusions, platelet transfusions, antibiotics, and iron chelation therapy for iron overload. Next slide. And there's a huge number of treatments that are out there, and I've just listed some of them here. As always, we recommend clinical trials if you can go onto a clinical trial. The only therapy that's known to be curative right now is a bone marrow transplant from somebody else. Next slide. So that's my talk, and we'll open it up to questions.
Thank you so much, Dr. DeCastro, for that wonderful presentation. Now we'll ask questions. Aaliyah, do we have any questions in the chat for the presenters?
Yes, and I'll start with, we have two questions for Dr. DeCastro. The first question is from Dr. Angelo Moore. He says that it seems that most symptoms for blood cancers are similar to cold and flu symptoms. What recommendations would you give to patients in which their symptoms seems to come often and are not taken seriously by their providers?
I mean, I think the answer is sometimes you have to be a persistent advocate for yourself. If your symptoms are staying around and not going away, I don't think that's the flu. It's got to get better if it's the flu. So, sometimes if it doesn't go away, you call your provider back and say, hey, I still feel horrible. What's going on? And hopefully they'll listen to you the second time or third time around and look at the blood work and decide what's going, if there's something real there.
Thank you. And the second half of his question is, are patient outcomes better with umbilical cord or bone marrow donations?
I'll let Nelson answer that one.
I think the answer is that it varies. So the current algorithm we have is that if you have a MAT sibling, we still use a MAT sibling. If you don't have a MAT sibling, we would use somebody from the registry, so an unrelated donor. And if you don't have either of those, we would probably use a cord blood if we have the potential of an expansion of cord blood, which is now available, so we can actually grow these cord blood cells outside of the body and actually give more cells that way. If we don't, and there's a certain time element, we might use a half a match. So in general, right now, we would say that the MAT sibling is still the best.
Okay, thank you. And we have another question here from Nadia. She says, are there any environmental or medicine exposures that can cause blood cancers?
Of course, there are. Environmental for sure. For example, benzene has been linked to causing leukemias. Medicine exposures, unfortunately, our own chemotherapy drugs that we've used to treat cancers for years can lead to myelodysplastic syndrome. And some of those are very difficult to treat sometimes.
We have a question for Mildred as well. Angela Moore says, how important is it for your medical team to communicate?
Can you repeat that, please?
He says, how important is it for your medical team to communicate with each other?
Well, it's extremely important. For me, like I said, with my local oncologist here reaching out to Duke, the fact that she reached out beyond her expertise is what made me go there and be able to connect with Dr. Chow and Dr. DeCastro. Fortunate for me, I've been well, but even now, depending on what I'm dealing with, it depends on who I'll reach out to. Sometimes I'll contact Dr. Chow for something, and if it's nothing very, very urgent, I'll stick with, my doctor here in Wilmington. but I do know that whatever's going on with me, at least they're communicating with each other. So it's really important.
Thank you so much. We have a question from Kirsten Ingraham, and she says, is there anything one can do to prevent, decrease the risk of developing the various types of blood cancers?
I don't think we know enough to know how to decrease the risk of developing various types of blood cancers for now.
Yeah, I would agree with that. I think, if you look at lymphomas, for example, the incidence has been going up. Whether that's the kind of food we're eating, whether it's microplastics, whether it's, the stuff we spray on our foods, we don't really know, but there's no doubt that the incidence has been going up over the last few years.
Thank you for that. And our last question that we have here is for both of you concerning Mildred. Nadia asks, what impacted you both about Mildred's particular case, and what do you think was the key to her success?
I think it was her faith. What's really interesting for me to recap patients' journey is, you see them back, they look great, they're feeling well in general, but it's a tremendous journey, and it is a miracle in many ways that it's been 14, 15 years, which is such a wonderful story.
And I got to interject right here. First of all, let me say to both Dr. DeCastro and Dr. Chow, I love you both, and thank you so much. I thank God for assigning both of you all to me. And Dr. Chow, you said the right word. Faith played a major part. That was a huge part. There were times, I don't know, I just didn't think I was going to get through, but I'm here. And it's only by the grace of God. And I think in his grace, he's blessed each one of you all. So it's a collective effort between God, you all, and my existence. And of course, the mother who knew then about donating to the umbilical cord bank, because 14 years later, that's still something that mothers don't know about. So that made a huge difference. So thank you both.
Thank you, Mildred. We love you too.
Thank you.
That's amazing. And someone else asked, what was the most helpful to you, Mildred, from your experience with the medical teams that you would like to continue?
What was the most helpful for me?
Mm-hmm.
I will say a couple of things. I'm not a nurse, I'm not a doctor, but I've always worked in the environment. I started off in the early 80s in Chicago as a unit secretary. And from that point up to this point, I'm still in the environment. I'm a medical coder now, but I say that to say just being in the environment of medicine or doctors or nurses, transcribing their orders, reading all that stuff, I think that gave me some kind of advantage or edge. I guess you could say a little outspoken. My mom I became her caretaker. So I think the combination of things, and then when yourself become a patient, you're able to see a doctor, then you're working with them, then you can have conversations with them. And so I think that played a major part for me. Yeah, because oftentimes when people don't know a lot about that environment and they get a diagnosis, they don't know how to communicate. They don't know what questions they ask. They don't know how to be proactive for themselves. So I think just working in the environment, it taught me a lot and it showed me what to do for me.
Yes, thank you. And going off of your point about the donating cord blood, there's a question. Are there any cancer education outreach programs working with obstetrician offices to educate pregnant women on the benefits of donating cord blood for blood cancer patients?
I'm going to say I've found in my advocacy that obstetricians are familiar with cord blood donation, and they do push it, but not so much on the public aspect. They tell moms more about saving the cord blood for themselves, as opposed to, you know, you got this option where you can publicly donate. But another part to that is there's not banks in every city or state, so that poses a difficulty. So like here in North Carolina, we know that Duke and UNC and Wake and, you know, a lot of our hospitals, but here in Wilmington, our New Hanover or Novant didn't do it. And it was because of my personal experience. I came back home in 2007 on fire about sharing the information, but it was another 3 years before Carolina Cord Blood had actually put together the possibility of a kit to even help the mothers here locally be able to do that. So it's out there, but it still has a lot to grow upon. Let's put it like that. But if anybody want to know more, I have a Facebook page, Driving for the number 4 and the word change, all one. If you have any questions, please look me up out on Facebook, and I'll be more than happy to help you with whatever your interests are in regard to it.
Thank you for that. I'll make sure we have a link for that Facebook page. We have a question for Dr. Chow and Dr. DeCastro. Are there any clinical trials that patients can participate in that you're aware of?
Always clinical trials. So, I mean, the information can be reached either through our own website, or if they're outside of Duke, there's a clinicaltrials.gov website that lists all the trials throughout the country for various cancers. Yes.
Thank you. And we have a question again about cord blood donation. The question is, can a pregnant woman store her cord blood in the event that she or her children develop blood cancer in the future? And if yes, how long is the cord blood viable? And is this covered by insurance?
So it's not covered by insurance. Cord blood would be viable for probably 20, 30 years. And the mother could store it for a child, but in general, we tend not to think that that is a great idea. You're storing the cord blood of a child for that child, and you just don't know whether the genetic makeup of that is going to be useful for that child. Supposedly, if it's genetic and it's disease, you wouldn't want to use the same source. So, but many people do store cord blood, and in the future, it's possible that these cord blood cells could be used for other diseases like, you know, heart disease or other things. But at this point, we tend to say that it's probably not reasonable that your child would ever need it.
Okay.
May I also add that usually when you store for your family usage, those are the banks that you end up paying. An initial fee to activate the storage and then a yearly fee thereafter.
Thank you for that clarification. And then we just have a comment from Nadia. She says, I served at Duke as an interpreter, and I interpreted for Blood Cord Bank, and I don't remember a single woman that refused to donate the cord blood, and they are happy to be able to contribute to saving someone's life. So thank you for that, Nadia. Do we have any other questions?
I have a question. Mildred, I noticed that in your bio, you are a certified patient navigator as well as a Duke Cancer Institute Office of Health Equity Community Health Ambassador. So what influenced you to take the steps in going through those 2 trainings?
The fact that I've worked in the environment, I've been a patient, I've been a caretaker. I have a grassroots organization that does advocacy to try to help increase, educate, and populate the bone marrow registry, so it all works together.
Thank you so much, Mildred.
You're welcome.
Now there's one more question, because I heard you say that your blood type changed throughout all of this. So how does that happen to Dr. DeCastro and Dr. Chow?
Well, the blood is made from the bone marrow. So when you have a bone marrow transplant, you actually get rid of the residual endogenous blood and you get complete new blood made from the donor. So the donor, so the blood type becomes whatever the donor blood type was.
Interesting. That's interesting. And so is there any other, what happens is that, does that person have younger looking skin? I always tell Mildred she looks younger than her age, and, you know, she has more energy than I do, you know? So could that possibly contribute to, you know, the blood cells of a baby? I mean, is it possible?
It's possible. In fact, we're actually doing some research on that, looking at whether the tissue changes. So in mouse models, actually, you can show that these cells probably help in regenerating, but there's really not much data in humans.
Mm-hmm. And one more thing that I also noted in these blood cancers, you may find that maybe African Americans show up less or tend to have these diseases less, but yet they have their outcome is much worse. So what are the indicators that would cause something like that with African Americans? Why would the outcome be worse, possibly?
Well, I think that's a complex question, ranging from both socioeconomics to genetics and to a lot of other things. And I know there's a lot of people studying these issues and trying to figure out exactly what it is for these blood cancers and why, or all cancers for that matter, and why certain ethnic groups don't do as well. So sure.
Thank you, Dr. DeCastro. Do we have any more questions or comments? All right. Thank you very much. Wonderful presenters, just wonderful, great stories, great information. And I just want to say that stay tuned to our September virtual series. We will have information in regards to prostate cancer awareness. We actually will have two, one on prostate cancer as well as ovarian cancer. So stay tuned. For those of you that have signed up for this August virtual series, you will receive information and marketing material for these two virtual series. So we'd like to thank our presenters. This was amazing, amazing. And we wish you luck, Mildred, moving forward. And we love your story. It's amazing. Thank you so much.
Thank you for having me.
You're welcome. And if we say good night to you, we give you the gift of time. Thank you so much for attending our August virtual series. Have a good evening. Thank you.
Thank you. Bye.
Bye-bye. Kirsten.